So let's apply some more basic sciences to real life. This is really fun and useful, and you should be aware of some of these underlying mechanisms because it will make it a lot easier on you in real life when you encounter these various situations. So we're going to talk here about the pentose phosphate pathway. This is kind of an ancillary pathway to glucose metabolism. A lot of people don't really consider it. And that's a shame because there is one very, very, very important disorder, especially if you're taking board certifying examinations. Step one is probably going to ask you some of the mechanisms behind this particular disorder, which we're going to talk about. And there really is only one disorder of the pentose phosphate pathway which comes up with relative frequency. So we'll start with a vignette. We have a 2-year-old African-American boy coming to the clinic with his mom. And she's concerned because he woke up this morning with yellow eyes. There are no other reported symptoms and the child doesn't appear ill. 2 days ago he was seen for a sore ear. He was diagnosed with an ear infection, acute otitis media, and was started on Bactrim, trimethoprim sulfamethoxazole, 6 milligrams per day. At the moment he's afebrile. Physical exam is remarkable for scleral icterus and yellowing of the palms, but it's negative for abdominal pain. There's no hepatosplenomegaly. Past medical history is unremarkable, aside from the fact that when he was a baby, he had some jaundice, which resolved with phototherapy. And his mom notes that her brother and her father occasionally get yellow eyes, but they are otherwise healthy. So we have a otherwise healthy appearing yellow person. What does this mean? Well, if we said that this was a 63-year-old alcoholic who comes to you and he's yellow, that would be a totally different story. But when you have an otherwise healthy, jaundiced person, our first thought is going to be hemolytic anemia. So we'll get our labs, and our CBC comes back with a mild anemia, 9.9. I would say something in the mid-10s would kind of be the lower limit of normal for a child. 9.9 is a mild anemia. Hematocrit is reflective of the hemoglobin at 30%. His MCV is normal, so this is a normocytic anemia. Peripheral smear shows Heinz bodies and bite cells. Heinz bodies is probably not going to be something that comes up right away on peripheral smear just because it requires a specific stain, but bite cells will certainly be visible on your peripheral smear, on your initial smear. BMP is normal. Liver function tests show a indirect hyperbilirubinemia. So that is what we would expect with a hemolytic process. So his total bilirubin is elevated, but it's the unconjugated fraction, the indirect fraction, that is contributing to this hyperbilirubinemia. His LDH is high. LDH is an enzyme which exists within cells. Anytime there's cell death, there's going to be an elevated LDH in the serum. Coombs is negative, meaning it's not an autoimmune hemolytic anemia, and his haptoglobin is low, which is going to be seen in all hemolytic anemias. So we know he has a hemolytic anemia. What's important here? Well, the yellow eyes, scleral icterus, yellowing of the palms, that's all reflective of hemolytic anemia. He doesn't appear ill. He was on trimethoprim sulfamethoxazole, or he is on it. This is an important drug and one of many drugs that contribute to this particular type of hemolytic anemia. Uncomplicated neonatal jaundice in his history, so this is a repeated sort of deal that he's got going on. And mom notes that her brother and father occasionally get yellow eyes, so there's a family history here. This is most consistent with G6PD deficiency, and what really points to G6PD deficiency are two things, apart from the fact that he's hemolytic. The fact that he is on a sulfa drugs can elicit symptoms in people with G6PD deficiency. Also the fact that he's African American. Blacks have a very high rate of G6PD deficiency compared to other races in the US. And then the fact, very important fact, that there's a family history. This is an X-linked recessive disorder, and this pattern, fact that mom's brother and father have this going on, is reflective of an X-linked pattern of inheritance. So we're going to briefly review the pentose phosphate pathway, and then we'll talk about G6PD deficiency in greater detail. So the pentose phosphate pathway is also known as the hexose monophosphate shunt, and it's considered a shunt because you start out with glucose 6-phosphate, you go into this pathway, and then you wind up with fructose 6-phosphate and glyceraldehyde 3-phosphate. But that's not a perfect term, shunt, because there are some products here that are very important. particularly ribose 5-phosphate as a product is important for nucleotide biosynthesis. And then one of the cofactors that comes into this pathway is actually going to get reduced, and that's going to be behind the pathophysiology of G6PD deficiency. So this is the pentose phosphate pathway. Obviously, we're starting with glucose 6-phosphate, which is a product of glycolysis and gluconeogenesis. And this very first step, going from glucose 6-phosphate to 6-phosphogluconate, is an oxidation reaction. And this oxidation is going to require a cofactor to receive that electron. And that is NADP, which accepts it, and you get NADPH out of it. This is different from NAD and NADH. NADP and NADPH do a totally different thing. So remember, this is an oxidation reaction, and an oxidation reaction gives up energy. Okay, so this gives up energy, and by using, what uses that energy is the NADP. Forming NADPH requires energy, and so you're using this reaction, which gives up energy, you're using that energy to form NADPH. Okay, so like I said, glucose 6-phosphate comes from glycolysis, gluconeogenesis pathway, and then these three initial steps here are irreversible. And what we form ultimately is going to be ribulose 5-phosphate, and then from there we have a reversible step. This is called isomerization or epimerization. Isomerization is how we form ribose 5-phosphate. It's just a rearrangement. And then epimerization is even less dramatic. You're just changing the position of one of the hydroxyl groups on the sugar. So we form either xylulose 5-phosphate or ribose 5-phosphate out of a single ribulose 5-phosphate. And it's ribose 5-phosphate, which is important here because this goes into nucleotide synthesis. And then from there we can have breaking and reformation of carbon-carbon bonds, and we can form these various things which you don't need to be aware of. But what ultimately does form out of this is glyceraldehyde 3-phosphate and fructose 6-phosphate, which can then go back into glycolysis and gluconeogenesis. Okay. So like I said, 3 stages. The initial few steps are going to be oxidative reactions, and these are irreversible, which makes sense because we're getting rid, or we're releasing energy, and so to go backwards would take energy, and we don't do that. Okay, so these are irreversible. It yields 2 equivalents of NADPH. The end product is that ribulose 5-phosphate. We take that ribulose 5-phosphate, and it can go in one of 2 directions. It can be isomerized or epimerized, and we can form ribose 5-phosphate or xylulose 5-phosphate. And then you can take ribose 5-phosphate, go into nucleotide synthesis, or you can take these and sort of rearrange the carbon-carbon bonds, and you get these various intermediates, ultimately forming fructose 6-phosphate and glyceraldehyde 3-phosphate. I wouldn't be too concerned about all these individual steps. What you should be aware of, though, are the principal products of the pentose phosphate pathway, and those products are ribose 5-phosphate, which goes into nucleotide synthesis, and NADPH, which is used as a reducing agent. Remember that reduction reactions require energy. And so it's very difficult to reduce things without having something that is holding energy and is able to reduce whatever is going into these reactions. Okay, so what is the difference between NADH and NADPH? As mentioned, NADH is different. NADH is what we get out of glycolysis, and it's that thing that goes into oxidative phosphorylation. It transports the electron in the mitochondria and gives off energy and is used to make lots and lots of ATP. On the other hand, NADPH is really just a glorious, glamorous reducing agent. Okay, it powers reduction reactions and is a source of reduction, and it's important in detoxifying hydrogen peroxide and organic hydroperoxides. Those need to be reduced in order to be detoxified. Otherwise, hydrogen peroxide and other hydroperoxides, they're very toxic to cells, and so they need to be detoxified. They need to be reduced. And it's not the NADPH itself that is doing the reducing. Okay, so I mentioned it's reducing agent, and it is, but it's not the NADPH itself that does the reducing. What's going to happen is NADPH is going to give you a reduced glutathione, and it's this reduced glutathione that is actually going to be directly the agent doing the reducing. Okay, so reduced glutathione is denoted as GSH. The S just stands for a sulfa group, and the H meaning that it's reduced. So you take GSH, and when it comes into contact with these organic hydroperoxides or hydrogen peroxide, it then can detoxify it, neutralize it into an alcohol and water. But in doing that, the GSH, the reduced glutathione, becomes oxidized. And when it becomes oxidized, the sulfa groups will form a double bond with each other, and it dimerizes. And what you get is oxidized glutathione. Oxidized glutathione can't really do anything. It certainly can't reduce anything. And so you need a way of regenerating reduced glutathione from these oxidized glutathione dimers. And there are two things that help you do this. First, the enzyme, glutathione reductase, but also the NADPH. The NADPH is going to be your source of electron for this reduction. And so the NADPH reduces these glutathione dimers, and now we've regenerated our reduced glutathione, which can then go back into detoxifying these organic hydroperoxides, hydrogen peroxide, and then we're left with an NADP. And that NADP itself really can't do anything, and we need to get NADPH back out of that so it can come back and do this reaction over again. And so if you go back and you look here, it's this step that's mediated through this enzyme G6PD that regenerates NADPH. And if you can't regenerate NADPH, then you have no way of doing this reaction here, this reduction of the glutathione. And so you don't have any reduced glutathione to detoxify the organic hydroperoxides and hydrogen peroxide. And if you can't do that, then you're going to have all this hydrogen peroxide, organic hydroperoxides in cells, around cells, and it can damage the cells. And that is why we get lysis of the red blood cells, because you have these peroxides which are just spontaneously formed, and it will damage these cells. So if you don't have NADPH, you can't detoxify these hydroperoxides, hydrogen peroxide, and the cells will become damaged. And that is that is the mechanism behind G6PD deficiency. Now, another important role of NADPH is it helps you form superoxide in neutrophils. So now, in this case, we're not detoxifying anything, we're actually forming something that's toxic. And this is important in neutrophils because, remember, neutrophils need to kill things. And so what we form with this NADPH is we get this 2O2 minus. This is superoxide. It just has an extra electron on it. And superoxide can then go and form like bleach and stuff like that, which is highly toxic. And that's good in neutrophils because neutrophils kill things. They kill bacteria, particularly catalase positive bacteria. So we need NADPH not only to help protect our own cells, but to form things that will destroy invaders, so things like bacteria and fungi. And this enzyme NADPH oxidase is what does that. What helps you form this superoxide. And if you don't have this, if this enzyme is defected, you get something called chronic granulomatous disease. Now, this is not a disorder of the pentose phosphate pathway because this enzyme is totally unrelated to the pentose phosphate pathway. But it just goes to show you that NADPH does other things. And if you can't form NADPH, you're going to have some problems. Now, we don't really see much of an immunodeficiency in people with G6PD deficiency, and what that probably means is that you can form NADPH elsewhere, or maybe you just don't need as much NADPH for the neutrophils to do what it needs to do as you need for the red blood cells to do what it needs to do, namely protecting itself. But this enzyme does come up, and that's chronic granulomatous disease, and these people are susceptible to catalase-positive organism infections. And catalase-positive organisms are things like staph, Pseudomonas, fungi like Candida and Aspergillus, Enterobacter, namely Klebsiella and Serratia, and some various other organisms. So chronic granulomatous disease causes immunodeficiency, but people with G6PD deficiency, they can make NADPH in sufficient enough quantities to where they don't really have an immunodeficiency. It's been described in some of the literature that people with G6PD deficiency may have a somewhat increased incidence of some of these infections, but really not enough to where it matters clinically. Okay, so as I mentioned, the erythrocyte requires this reduced glutathione and hence NADPH to maintain membrane stability. If it can't do that, if you have a G6PD deficiency and you're not forming enough NADPH, you're going to have problems with your red blood cells. They're going to become easily oxidized and damaged, and then they're going to lyse. Okay, so G6PD deficiency is a deficiency of the enzyme glucose 6-phosphate dehydrogenase, which results in a significant deficiency of NADPH, or at least enough to where it causes a hemolytic anemia. The major site of pathology here is, of course, the erythrocyte, whose membrane becomes unstable and hence renders the cell at risk of lysis in response to oxidative stress. Now, the red blood cell itself doesn't really need NADPH. It needs NADPH when it comes into contact with oxidative stress. Inevitably, a cell, however, is going to come into contact with some oxidative stress. There are certain things that you can do that is going to make that oxidative stress worse. So like eating fava beans, taking sulfa drugs, drinking red wine. All of those things increase the oxidative stress on the red blood cell. So those things are going to precipitate particularly bad forms, particularly bad episodes of hemolysis. But you're always going to have some level of hemolysis, even at a lower level, because there's always some level of oxidative stress. But this is the reason why if these patients, they take a sulfa drug or they eat fava beans, that oxidative stress becomes much worse and it's going to precipitate an episode of jaundice and hemolysis. This disorder is X-linked recessive, as we alluded to earlier. This is very important because a lot of those disorders of glycolysis that we talked about in the other section, those are autosomal recessive. This is X-linked recessive. So primarily, this is going to be a disorder of men, of boys, because all they need to have is their moms be carriers, and then they have a 50% chance of being affected. For girls, they need to have both their father being affected and their mother to be a carrier. And that obviously is statistically much less likely. So in the US, it is most commonly seen among black males. Worldwide, it is seen among Africans, Middle Easterners, among tropical, subtropical Asians, among some Mediterraneans, and indigenous people of Papua New Guinea. But which of these populations is really the largest in the US? It's the black population, and so we see it most commonly among blacks, particularly males, because it's X-linked recessive. So the prevalence in the US is estimated at 2.5% among males, 1.6% among females. That is really interesting because this is an X-linked recessive disorder. That just goes to show you how common these carriers are, that there are females that are affected, because you would require an affected male, affected father, and a carrier mother, or an affected mother. So among black males, the incidence is 12.2%. Among Asian males, 4.3%. Among black females, 4.1%. Of course, more common among males because it's X-linked recessive. So why, or what does this look like? That it's a blood disorder primarily affecting blacks. What also does that? And Asians to a lesser degree. What also does this? Sickle cell disease. Sickle cell disease is also very prevalent, relatively prevalent among blacks in the US. And there's a reason for this. Both being a carrier of the sickle cell trait and being a carrier of the G6PD trait, they both confer some level of resistance to a very, very, very important pathologic parasite that occurs in these locales. And what is it? I'll give you some time. You should know what this is. It's malaria. Malaria is something that's obviously very prevalent in Africa, very prevalent in tropical, subtropical Asia, Thailand, Vietnam, and this is why this trait exists in these people, because at one time they were in an area where there was lots of malaria, and this trait that these red blood cells can lyse before these malaria can come into the red blood cell and reproduce, which is where they reproduce. This is actually protective to have the trait, but when you have when you actually have both affected genes, or in males you have the one affected gene, then obviously you can get disease from that. So in sickle cell disease, it helps to be a carrier. Now with G6PD deficiency, if you're a man and you have the affected gene, because it's X-linked recessive, then you will have the disorder. Now luckily, G6PD deficiency is not as problematic as sickle cell disease. G6PD deficiency, for the most part, you go on living your life, you're going to be totally fine. You just get these episodes. But it's an important linkage here, because that is why we continue to see these traits among these particular populations, because they historically come from regions where malaria is around. Okay? So this is the X-linked recessive inheritance, which you should remember back from basic genetics. If the mother is a carrier, she's not going to be affected because she has two X chromosomes. But there's a 50-50 chance that her son is going to be affected, providing the father's not affected. So one of those X chromosomes is going to go to her son. It just depends on which one, 50-50 chance. Now her daughters, on the other hand, will not be affected provided the father is not affected. So the daughters will there's a 50-50 chance that she will be a carrier, but she won't be affected. The only way a daughter becomes affected is if her father is affected, her mother is either affected or a carrier. Let's say her mother is a carrier, then it's a 50-50 chance, right? She gets the X chromosome from dad and one of the X chromosomes from mom. If she gets the affected chromosome from mom, then she is going to be affected. If she gets the non-affected chromosome from mom, that chromosome will dominate and she will just be a carrier. Now, on the other hand, let's say that she has an affected father and an affected mother. What's her chance of being affected? 100%. She's going to get an affected X from mom, affected X from dad. Same for the sons. He's going to get one of the affected X chromosomes from mom. Doesn't matter about dad. So and let's say if dad is not affected and mom is affected, all her sons are going to have it because he has to get an X chromosome from mom. Both are affected. Okay, so that's just some basic X-linked recessive inheritance genetics for you. So on presentation, most patients are asymptomatic most of the time. It's when they come into contact with an oxidative stressor where they're going to develop symptoms. They'll show their symptoms. Sometimes they can have a neonatal jaundice when they're born, but lots of babies get jaundiced. So that's not going to necessarily point you towards some kind of pathologic process. You can get physiologic jaundice in infancy. So that really doesn't help us too much. So what's going to happen is they're going to get jaundice, sclerolicterus. Those are going to be the most prominent symptoms. Occasionally, because they get all this excess bilirubin spilling out, it can cause some cholestasis in their liver that goes into the liver, and that can predispose them to getting gallstones. And so they can get right upper quadrant pain if they've got an obstruction, but that's rare, or more rare if you compare it to jaundice and sclerolicterus. You have to have jaundice and sclerolicterus, you have to have a lot of bilirubin coming out in order to develop the gallstones. But they do have a predilection for gallstones. Fatigue, malaise are less common simply because it's not as severe of a hemolytic anemia as you might expect. It doesn't take a whole lot of hemolysis to get to jaundice and sclerolicterus. Very rare that you're going to see these patients to the point where they're going to require transfusion. A lot of times these patients will chronically sit in the low normal range, and then they come into contact with these oxidative stressors, and they might go into the 7s, 8s, or 9s. Okay, so what's rare is these frequent infections. Remember what I don't know if I alluded to it earlier, but there's varying degrees of G6PD deficiency. So you may have 90% deficiency or a 40% deficiency. Some of the lower levels of deficiency where you have some enzyme, that might just give you this jaundice and scleral icterus from time to time when you come into contact with oxidative stressors. If they have a much more severe G6PD deficiency, certainly they're going to have a much more severe anemia, and they may even get infections because, remember, you need that enzyme to make NADPH. If you don't have it, you're going to have less NADPH. And remember that NADPH is important for developing those toxic superoxide and bleach that your neutrophils need. So you'd have to have a very serious deficiency in order to develop these frequent infections. Like I said, most of these patients will just have the intermittent jaundice and scleral icterus, which can be correlated to drugs or foods that cause oxidative stress. So our workup is going to be sort of your basic workup for hemolytic anemia. You're going to get a CBC and a smear. You get a BMP, liver function test looking for indirect hyperbilirubinemia. Get a hemolytic anemia workup. You're doing a Coombs test to look for autoimmune hemolytic anemia, the pi-linked antigen looking for PNH, osmotic fragility test looking for spherocytosis, and a haptoglobin, which we would expect to be low. And that just continues to confirm your diagnosis of hemolytic anemia. Additionally, you can get LDH too. A sonography should be ordered if there's right upper quadrant pain. So what do we expect to see? Well, probably a mild anemia in most patients. Heinz bodies, you're not really going to see those unless you do that special stain for that, but bite cells are going to be something that you'll see. And what the bite cells are from, well, I'll show you a picture in a little bit. BMP should usually be within normal limits. Liver function tests, elevated indirect hyperbilirubinemia. The hemolytic anemia workup is going to be negative Coombs, negative pi-linked antigen, negative osmotic fragility test, and elevated haptoglobin. What we just did here was eliminated some of the other forms of hemolytic anemia. And the sonography, if there's right upper quadrant pain, may show cholelithiasis. If you were to just get a sonogram, you may see gallstones, even if they don't have right upper quadrant pain. But there's no need to get a sonogram if they don't have right upper quadrant pain. The confirmatory test here is quantitative G6PD levels, which will demonstrate not only do they have G6PD deficiency, but how severe it is. Okay, these are Heinz bodies, and what Heinz bodies are denatured hemoglobin. And that hemoglobin becomes denatured because you have you don't have the NADPH to protect it against oxidative stress. And that ultimately is going to lyse the blood cell too. But the hemoglobin will be affected even earlier. And so you'll have oxidized hemoglobin, and that's what we see. That's the Heinz body. If you're taking step 1, you should know what a Heinz body is, what it looks like. Now, the bite cell is going to be more easy to see because you don't need a special stain for that. And all a bite cell is when the blood goes through the spleen sees whatever is abnormal. If the blood cell is really abnormal, it's just going to take it out of the circulation. But if you have a red blood cell that comes along a spleen, has a little Heinz body on it, the spleen is going to take a bite out of that red blood cell and take the Heinz body out. And that's what you have here. Notice this little bite out of the periphery of the red blood cell. All this means here is that the spleen saw this Heinz body, took a bite out of it, and now you're left with a bite cell. Okay? What do we do to manage G6PD deficiency? Most of the time, this is not a really big problem. All we need to do is make sure that these patients avoid what they can avoid, avoiding oxidative stressors. Your responsibility as a physician is going to be to educate these patients. So what drugs do they avoid? Classically, you hear anti-malarial drugs they need to avoid, and that makes sense. But how often do you prescribe anti-malarial drugs in the U.S.? I've only, in my entire career, ever seen one patient with malaria, and I can tell you they didn't catch it in the U.S. So anti-malarial drugs, yeah, that's classic, but tests are probably not going to tell you, well, the patient was on Primaquine and they turned yellow. No, in the US, they're going to be on something else that causes the trigger. And so some of the more common drugs that you prescribe in the US that are G6PD triggers are going to be aspirin, NSAIDs, sulfa drugs, so sulfa antibiotics, also things that you give for some of the rheumatic diseases like sulfasalazine, fluoroquinolones, nitrofurantoin, and then quinidine, quinine, antimalarials, and high-dose methylene blue. When do we give methylene blue? We give methylene blue for methemoglobinemia. Not something you come in contact with that often. So for the test, there's a big list of drugs that are triggers for G6PD episodes. But the ones that you want to remember, of course, remember antimalarials because that's classic. But the test, because it's the US MLE, is going to probably give you a vignette that's common in the US. And so what do we prescribe frequently in the US? Well, we don't prescribe aspirin and NSAIDs so much. Those can be taken over the counter. Sulfa drugs, like trimethoprim sulfamethoxazole, like sulfasalazine, and then fluoroquinolones. We give these a lot in the US, and then nitrofurantoin as well. Okay, what about foods? So fava beans are classic, but that's so obvious. You see a vignette that says fava beans, oh, it's G6PD deficiency, duh. The test is not going to be that easy for you. They're not going to make it that easy. So what are some other things? Menthol, which you find in some toothpastes, peppermints, soy products, soy sauce, red wine. Why red wine? It has nitrites in it, or sulfites in it. Sulfites can precipitate G6PD episodes. Garbanzo beans, menthol. Okay, I put menthol twice, but remember menthol. Okay, so peppermints, toothpaste. Tonic water. Tonic water has quinine in it. That's why. And then blue food dyes. Another thing is blueberries, probably because of the blue dye in it, but blueberries can also do it as well. So kind of a random list of foods. They don't really have any relation to one another, at least that is apparent. But you'll want to remember these at the very least. So there's a lot of foods that can trigger a G6PD crisis. But these are the ones that I see more commonly come up on the test, and also the ones that are more commonly consumed in the U.S., especially soy products, red wine, menthol. Folic acid supplementation. So this is another step in management. Why do we give them folic acid supplementation? Anytime you have a patient who's having dying cells, you want to give them folic acid because these patients are hemolyzing. They need to form more red blood cells to make up for those cells that are dying. And so they're going to probably have an elevated reticulocyte count, indicating that their bone marrow is making more and more red blood cells. And because you're making more cells, you require folate and B12. At the very least, you want to give folate supplementation. And affected neonates should get phototherapy. That's standard management for any neonatal jaundice. Okay, so what do we want to avoid? I like pictures. At least pictures for things that are difficult to remember. And the foods are difficult to remember because they don't really show any apparent similarity amongst them. So remember, we want to avoid fava beans. Probably not going to get this on the test because it's so obvious. We actually, one of the old names for G6PD deficiency is favism. Fava beans are eaten a lot in the Mediterranean, Middle East. Not so much in the US though. Chinese herbs. I didn't really talk about this, but there are some Chinese herbs that you'll see that can trigger this. Again, not consumed very often in the US, but remember Asians are particularly affected by G6PD deficiency, and they might consume these. Soy. So again, another sort of staple of the Asian diet, and so this can, and we do see soy a lot in the American diet too. Go to a Chinese restaurant, put soy sauce on your rice or on your... I heard once that putting soy on your rice is like a total anathema to Asians. They don't understand it. But we in the US do that all the time. So put soy on your Chinese food, boom, G6PD episode. Red wine, very common in the US and in the Mediterranean too. Interesting. So Mediterraneans have a high incidence too. So red wine has sulfites in it, and that is actually what's behind the trigger. Menthol, we see it in peppermints, toothpaste, blueberries, and tonic water. Tonic water, look at here, contains quinine. Why are they telling you it contains quinine? That's silly. They tell you it contains quinine because people with G6PD deficiency are told to avoid quinine. Well, tonic water is just water, right? You go get your gin and tonic, you think nothing of it. Well, it's got quinine in it, and if you're G6PD deficient, this is trouble. Okay, so you might ask yourself, just in closing, you might ask yourself, why, when these people come into contact with fava beans or red wine or soy, why are they, how come all their red blood cells aren't hemolyzing the same? And they go into just total severe jaundice, hemolytic anemia, and they die. The reason for that is because, remember that picture of the Heinz bodies. Those red blood cells that had the Heinz bodies on them, they were certainly exposed to the oxidative stress, but they didn't lyse. And the reason for that is that not all cells are going to lyse when they're exposed. Even G6PD deficiency, not all of them are going to lyse. Those younger, healthier red blood cells can typically get by. It's going to be the older red blood cells, the already kind of sick 90, 100, 110-day-old red blood cells that are going to hemolyze when they come into contact with oxidative stress in G6PD deficiency. So only the old cells are going to die off. And ultimately, new red blood cells are going to be created. And so this disease, even when you come into contact with oxidative stress, is going to be self-limited because you start creating new blood cells and the average age of your red blood cells becomes younger. And so you can get by even if you continue having the fava beans or the blueberries or what have you. A lot of times this will resolve on its own, and that's because you're making younger blood cells which can withstand the oxidative stress. So this actually does tend to be self-limited. It's going to be those really severe deficiencies where even the younger cells are going, younger and younger cells are going to be are going to hemolyze when they're exposed to the oxidative stress. So because only a fraction of the red blood cells, the older fraction of the red blood cells will actually lyse, they don't have a very, very severe hemolytic anemia. And that severity is really going to just vary based on the level of G6PD deficiency that they actually have. Okay, so if you have any questions, write me a note below. Otherwise, I will see you in our next talk.